Good afternoon to those of you phoning in from the Eastern U.S. Good morning to those of you in the Pacific and Mountain time zones. Welcome to today's Health IT webinar. Today's webinar will focus on mental health specific mobile applications and video conferencing-based telemental health. These webinars are brought to you by the SAMHSA Behavioral Health Information Technologies and Standards, or BHITS, initiative. My name is Alan Mogul. I serve as an associate scientist with Apt Associates, part of the BHITS team. Just a reminder to our participants today that, as usual, a PDF of this PowerPoint presentation will be emailed to all registered participants for this webinar. This webinar is being recorded, and it will be posted to SAMHSA's YouTube page at www.samhsa.gov. Please note that all lines are muted. You can submit questions via the chat box feature, which is usually found in the lower right portion of your screen. And as usual, we'll save all questions for the final 15 minutes. We have two distinguished speakers who will share some information with us, and we'll get to the first speaker presently. It's my privilege to introduce to everyone Dr. John Torres. John is an MD and has a master's in biomedical informatics, or MBI. He serves as the director of the Digital Psychiatry Division at Beth Israel Deaconess Medical Center, which is a Harvard-affiliated teaching hospital. Dr. Torres is a member of the American Psychiatric Association's Committee on Mental Health Information Technology. So, Dr. Torres, the microphone is yours.
Excellent. Thank you for having me, and thank you for all of you guys for tuning in and listening. So perhaps for the next 25 minutes, we're going to talk a little bit about mental health apps. What are they doing right now, and what are some ways that you can make informed decisions about them? If a patient or a client brings you an app and says, "What do you think of it? Should I be using it?" I guess the background question is, how would you respond? What would you say today? What would be your kind of toolkit or go-to responses? So hopefully at the end of this 25 minutes, you'll have a better idea of what these apps are doing, where they're heading, and what are some kind of strategies you can use to make sense of this space. So let me advance to the next slide. So the goals of this talk are to provide an overview of the current landscape and future of mental health apps, to provide an overview of the American Psychiatric Association's app evaluation model for informed decision-making using apps. The first objective is to describe the privacy and security issues regarding these smartphone apps. The second is to describe current evidence for as well as against using apps. Third is to describe usability issues of apps that patients may encounter. And the fourth is to describe appropriate data sharing and interoperability related to these apps. So I think, oops, I went one slide too far. We'll go back there. So I think the reason that we're talking about apps in mental health today really starts with the idea of access. And we all know that there's a crisis in accessing mental health services. No matter what country you live in or where you are, there's always an access problem for mental health. And one thing that there's not an access problem for is smartphones. Increasingly, people have smartphones today. The graph on the left is a review paper we did with Joe Fairth, who's in Australia, but you can see that we looked at the literature for those with psychosis, which is the darker blue line. And you can see those people with psychosis are owning phones. This wasn't smartphones, but look at how quickly the rate of phone ownership in those with psychosis is increasing. The top line that is dollar is the general population, but you can kind of see there's a closing of the digital divide. People with psychosis, with schizophrenia, are increasingly owning technology at a rapid rate. So while there may have been a digital divide in the past that some patients with mental health disorders couldn't access technology, increasingly that's not true today. And what I have on the right is a screenshot. I have no affiliation or link to Q-Link, but what Q-Link is claiming is basically if you're eligible for government subsidies to get a phone, what some of the patients I see are calling Obama phones, actually you can get a free smartphone now if you qualify through the right program. So in some ways it's actually hard to get to not get a smartphone if you're seeking a phone today. And I think we know that if you go to a retailer for $50, you can probably have a smartphone. So I think the access issue really has driven interest in these mental health apps because increasingly patients can own them and do own them. And I went one slide too forward. So again, what is the potential? If people are owning these devices, what can you do with them? And on the left, I have a picture we took of a study that we did a couple years ago where basically we asked people the PHQ-9, which is a depression screening scale that we use in the clinic. It's used in primary care and it's used in psychiatry. And we asked patients with depression to fill out the PHQ-9 paper. You see it below there. And then we asked them to do the same scale on the smartphone app that we developed. But we said, do this every day on the smartphone app for 30 days and come back after 30 days and then take the paper survey again. And what we found was people report symptoms differently on a smartphone. People reported more thoughts of suicidality and self-harm on the smartphone than they did on paper. So it's certainly very interesting. You can kind of get daily and sometimes more than daily surveys via these devices. You can learn about how patients are functioning, how they're experiencing their mental illness on a day-to-day basis, not just when you see them in the clinic. The right panel is this idea of passive data or sensors. And this was a picture from a popular press magazine. You guys will have the slides so you can look it up and get to details. But the idea is these smartphones have a lot of sensors on them that are collecting information passively or automatically. Your smartphone knows where you are all the time because that's how you're getting calls. Your smartphone has an idea of how many outgoing and incoming calls you got as just being a phone. So the question is, are some of these sensors useful for learning about people's behavior? So one word could be digital phenotyping that was coined by J.P. O'Neill at the Harvard School of Public Health. But could we use these smartphones to understand behaviors that people are doing? And you can imagine for a smartphone sensor, as long as you have the smartphone on, there's some data being collected. If you're doing surveys like on the left panel, sometimes people may not want to take surveys. Certainly, people will stop taking surveys after a while. And that brings us, oops, sorry, double click again. Let me close that. So let me go back again. Sorry, it keeps going to the same slide. I wonder, can we go back? Okay, sorry, so forward. I apologize to all you guys listening, there's a lag on. So that's where we should be, the potential of intervention. So on the last slide, we talked about there's new ways to learn about how people are experiencing mental health conditions via surveys or using these sensors. And I think there's also the potential of using the internet and especially smartphones to deliver interventions and offer mental health services. And figure 2 is actually something that is a survey result that came out from a group in San Francisco called the Hope Lab. And they did an interesting cross-sectional survey of how youth are using the internet towards mental health. And it's a very interesting report that you can download and read for free. And what they show in my summary of it is that some youth are turning to the internet and online resources like websites and apps for mental health. Some people are finding it helpful. Some people are finding it unhelpful. We don't really actually know a lot how youth are using these resources for mental health. What's interesting on the right is a figure of a smartphone app. You can see also a tablet and a web program that was developed by Joe Tai of the Black Dog Institute in Australia. And they actually developed this program to help address suicidality in Aboriginal populations in Australia, because there's limited access to mental health in regions of Australia. And working with these Indigenous populations, they were saying, can technology be used to reduce suicidality? So tackling a very difficult issue in mental health. And they actually published some interesting results in that citation showing the potential of technology to actually decrease suicidality in a community using technology. And the reason you see on the front is he didn't focus just on technology. It's a broader picture. They did a lot of work on community stakeholder work. They didn't just drop in and say, here's an app, use it. But it certainly is a case that you can read about where these interventions are being used for very important, often difficult psychiatric issues. So there it goes again, 2 slides. I'm going to go back. Sorry. Let's go back and back 1. So hopefully it stays here. So the reality today, though, is just because we can build an app or have an app and it's accessible to people, it's free to use on a smartphone, doesn't mean it's going to be used or it's going to improve mental health. My group at Beth Israel Deaconess Medical Center here, we do a lot of work in psychotic disorders. We look at schizophrenia especially, and we were interested in learning about how a popular app that targets schizophrenia is being used by the general population. So we had a research agreement to look at this app called SARDA Health Storylines, which is free to download. You can find it on the iTunes or Android store by typing in the word schizophrenia. And what we were interested, we said this app had been out for about 1.5 years when we signed a research agreement and were able to get the anonymized data of who logged in and who used the app. And we said this app has been out for 1.5 years in the US, it's free to use. We were interested how many people have downloaded the app and actually started to use a feature, and it has a medication tracking feature. And what you can see on the left is a screenshot of what is the commercial marketplace for it. It kind of tells you it's on Google Play, it's on the App Store, and you can use it on the web. And on the right, what we did was using anonymized data. We didn't know who the people were. We just knew that 225 people had used that medication feature once. So across all of America over more than 12 months, 225 people had once used a medication feature. And what you can see is this decay curve in some ways, that a lot less people used it twice. And by the time you get out to who has actually used this feature 50 times, it's less than 100 people. Who has used this feature 100 times, it's about 50 people. So you can see, just because you have access to an app and it's free, we really have to say, what happens next? Access is the first step. Are people using it? Are people engaging with it? Or are people dropping off very quickly? So I think that's one of the realities we have to think about today. The other thing that we have to think about is there's a lot of data being collected by these apps, especially they're collecting sensor data. The app may know where you are. It may have access to your call and text records, your contacts. Where is that data going? And I like to tell patients we work with sometimes the price of a free app is often yourself. And you would say, what does that mean? You are the price of a free app. The point being, a lot of these apps actually fall outside of HIPAA and federal privacy protections for health information. And in essence, we'll talk about later, the privacy policy may not favor people using the app. Again, you may be giving the company that built the app access to much of your information in return for using it. Another issue is these privacy policies are often very complex to read. I think anyone who's ever looked at or clicked on one of those app privacy policies has seen what someone once called mouse print. It just kind of scrolls and scrolls and scrolls all of this text. And certainly things that we don't want to happen if app data happen. That picture on the right is a news story from this year in Australia. It says medical appointment booking app, Health Engine, sharing clients' personal information of lawyers. So if you were using this app to book an appointment, they were selling your information perhaps to lawyers to inquire if you wanted to file malpractice claims or other insurance issues. And certainly that caused an uproar, but it's a case that what happens to your data when you use an app may not always be what you are expecting or hoping. The other reality today is not all software is good or useful. The figure on the left is an interesting one called the Momo Challenge. It's not app-based, it's software. It's kind of, you can read about it. no one quite knows what it is, but there's some concern, there's some software that kind of has challenges that are encouraging youth to hurt themselves. This article was saying perhaps did someone commit suicide because of this online program or challenge. Last year, there was something called the Blue Whale Challenge that there was some concern, was there kind of software running around or social media groups that were encouraging suicide. One that's perhaps more tangible on the right, this is a short personality test. The person entered, I don't like to talk a lot, and you could click a button. And this actually is Cambridge Analytica that led to that Facebook privacy scandal that we all have heard of and know of. But it actually started as kind of a mental health personality test that you were taking, and you gave it access to Facebook and other parts of information. So certainly not all software for mental health around health is good, or some of it can certainly be used for nefarious purposes. But the real question is, what is this stuff doing today? Does it work, and how does it work? So highlighted below are a summary of 2 meta-analyses that we did with Joe Fear. The references are there. And what's interesting is we look for randomized controlled trials of smartphone apps. On the left, you see for anxiety, on the right for depression. Because we said, what is the evidence that the smartphone apps are actually working? And what we found that's most interesting, I want to highlight, is a lot of studies will say, the smartphone app works very well, but you say compared to what? And if it's compared to a wait list, i.e. someone is not offered any services and one group gets the app, you can imagine the group that gets something is always better than nothing. And a lot of studies are reporting, they say this app is really great compared to nothing. And when you give an active control, you can see on the bottom left of that figure, so an active control being a different exercise, extra therapy sessions, a self-help book, an exercise plan, some type of control. The effect size for the apps for anxiety, half of the effect size went away, right? From 0.45 to 0.19. For depression, it was similar. Versus a wait list, it was 0.56. Versus an active control, it was 0.22. So when you see a study that says this app is effective, the question you want to ask is, again, effective compared to what? What type of study was it? And again, so that's understanding the context. So we do think these apps can work. Again, these studies are not negative, but the effect size of these apps may not be as big as maybe currently promised or that we kind of see. Another question is, people are certainly using apps today. People are certainly interested in apps, and this is unpublished data that we have in review. But what we did is we asked about 100 patients at a private insurance-based clinic in Boston on the left, and about 87 patients in a Department of Mental Health outpatient clinic on the right. And what you can see is the legend is the black line is who owns a smartphone. So in the left, we'll focus on, in the private clinic, many people in Boston, an urban setting, owned a smartphone. And red was many people have owned a smartphone, downloaded an app. Green was we asked people, have you actually ever downloaded and tried a mental health app? And you can see just because you own a smartphone and you're in a mental health clinic for treatment, a lot less people had actually downloaded a mental health app. You can see the younger group, under 25%, 80% had tried a mental health app at one point. Blue was, are you currently using that mental health app? And you can see that, again, we actually didn't have very many people in the under 25 group, but the younger group, it said they were using a mental health app, but in general, we found a lot of people were not using a mental health app. If we switch over on the right panel to the state clinic where people mainly have schizophrenia or bipolar disorder, you can see that smartphone ownership is a little bit less. Less people have ever tried to download a mental health app, and even less say they're currently using a mental health app. So it's one thing for people to be interested in apps. It's perhaps a little bit self-disclosure saying, John, are you interested in going to the gym? I'm very interested in going to the gym. Do you actually go to the gym and every day and use it? Those are very different questions. So everyone may be interested. Are they actually using it? And what we can't assess on this data is just because you're currently using it, is it impactful? Or is it like going to the gym and not doing the right exercises or not using it in the right way? So I think what I've just presented to you guys is an overview of the landscape. We have a lot of access, we have a lot of potential, we have some issues on are these things working and who is using them. And it can be very challenging in that landscape to say, what is the right app? What should I be using? And I think something that I initially thought was a nice way to kind of understand apps would be, well, if I log on to the commercial marketplaces, the iTunes or Android store, and look for apps that have high star ratings. If it has 5 stars, that's probably going to mean it's a better app. And there's a very interesting paper by Karen Singh that you can look up in the reference. I have a screenshot on the left where he basically showed that the app star rating doesn't really tell you much about the clinical utility or the usability of the app. It's a pretty unuseful metric. And there was actually a paper that came out in the last week that showed there was an app for blood pressure, and the app for blood pressure had a problem. It always basically said your blood pressure was too low. You were healthy no matter what. And they found that because the app told people they were healthy all the time, it got reviewed very highly. And when the app actually told you your real blood pressure that you weren't doing as well, it didn't get reviewed as highly. So star ratings can actually be very subjective, and there's a lot of concerns about what they actually tell us. So, and I said, expert reviews can be useful, but think of your phone right now and think how many apps want to update. My phone wants to update 23 apps right now, and I had updated everything 2 weeks ago. So even if an expert does a very good job reviewing an app, how quickly is that review going to be out of date in a world where apps change very quickly? So in some ways, it's nice to have an expert review, but they can quickly be out of date and become misleading. So if I advance to the next slide, another point is it's tempting to kind of say, can we have different scores for apps? Can we have point-based systems? Can we have kind of repositories that say these are the best apps? And the reason why it's challenging to have kind of a score-based system saying these are the A+ apps, these are the B apps, or these are 87 out of 100 is we don't yet know what makes a good app. We don't actually know what is in that figure. What is a bullseye? What is a great app? And we actually don't know what is a way that we can reliably, that different people can look at an app and agree. And as we'll talk about, just think about usability for a mental health app. Different people that you work with, you see, some younger people may find an app very usable. Some people that are more tech literate may find an app very easy to use and intuitive. Other people may find an app really hard to do. In some way, it's almost like saying, are we ever going to say medication X is the best medicine for depression and CBT is always the best medicine for depression also? No, we're never going to we're going to personalize our recommendation. We're going to personalize the treatment, what we're going to use, the tools, the medications to who is the patient at hand, what are the clinical needs, what works for them, what are they comfortable with. And I said, so we certainly don't have an index where we say the best medicine is always going to be X for this, or the best therapy is always going to be problem-solving therapy. So in some ways, we don't really have good metrics for what's reliable or what's valid in the smartphone app world. So if I go to the next slide, so what we've done at the American Psychiatric Association is we've built this hierarchy or framework, and the idea is not to give an arbitrary score. We don't want to give a metric which would be misleading and say this is a 85 out of 100 app, because again, these apps are going to update and we don't have a gold standard of what is the best app. We're also not formally endorsing an app. Instead, we're focusing on shared and informed decision making. And what I mean is, what I'm going to cover now is, you can use this hierarchy to guide a discussion with a patient, to guide a discussion with yourself on what do I know about the app? Does it make sense? And we're going to cover these different parts in the hierarchy. You don't have to know the answers to all of them. We don't have a cutoff, but by even thinking about the risks, the evidence, the ease of use, and interoperability, the hypothesis is that will lead you to make a more informed decision. Or you can use this to talk about with a patient, here's some risks to consider, here's some evidence. Is this something you want to do? And again, considering risk and evidence is risk-benefit. That's common decision-making as clinicians we all do. Considering usability and adherence is also something we do. We want to make sure that recommendations we give can fit into people's lifestyles and needs. Considering interoperability is considering how is, if someone's going to use an app, how is that data information going to get back into the treatment plan? How are we going to learn about it? We don't want to silo people's information where an app knows your medications, a different one knows your therapy, a different one knows your exercise. Who's overseeing all of it? So the first risk I think to consider or talk about is privacy and security. There's some evidence, and there's increasing evidence, that a lot of apps don't actually offer the right security that our patients or us would want for their data. And this happens, again, partially because a lot of apps fall outside of HIPAA. HIPAA does not apply in the top right corner to many health apps because they say they're wellness apps. That means the privacy policy ends up dictating what happens to the data that you or a patient puts into the app. So one very quick test to understand if an app is protecting your information is there even a privacy policy? We've done research and we found that many apps actually won't even offer a privacy policy. So just by checking for the presence of a privacy policy, you may be able to screen out half the apps, or at least a good majority of them. And certainly reading a privacy policy is not fun, but there's a couple apps that you're interested in. It may be worth investing some time to understand what actually happens to your patient's data or your own data. Are third parties having access to that data? And we talked about earlier, some apps just are misleading or not great. There's the Blue Whale Challenge app we talked about that was running around, perhaps, again, encouraging people to commit suicide. The Schizophrenia Don't Lose It app is an app that tells people not to lose their mind in schizophrenia, but actually becomes a Pong game where you try not to lose the pill. This was an addiction app, a screenshot. You can be addicted to being right or collecting things. So someone just kind of put up these things of different addictions you can manage. It didn't really have any medical backing to it. This was a screenshot from a different app that said basically part of your job is dedicate yourself to your own healing and therefore avoid being readmitted. Help yourself by helping others. Be your own NHS. And again, these are perhaps not, perhaps the right one's not harmful, but this is not the right information you want to be telling people per se. There's more evidence-based information you could guide people to than telling people help yourself and don't be admitted to the hospital. So what we're saying, I said, we propose some questions on the right in that right box, and they're on the APA website. They're free to access. We're going to be doing more work to simplify these questions in a couple of months, upcoming months. But what you can say is we're saying have a conversation and document that you told patients, did we consider the risk? Did we look at the privacy policy? Some people may say, hey, in the digital world, I'm okay with sharing my data. I understand my data is not private. Some people may be very concerned and say, if this app is sharing my data, what is being shared? I want to know the details. So there's no hard and fast rule. The questions we propose on the right, such as, is there a privacy policy? What data is collected? Is your data de-identified? Can you delete data, etc.? These are meant to be used to inform a decision, to think about it, and to come to a sense of, does this make sense for the person at hand, the clinical need to use? And I said, we'll be providing more filled out examples on the APA website soon. So talking now about evidence, I think evidence in these apps is very tricky. And I said, Headspace is an app that's very popular. Many people use it. This is one study. There's many studies that are positive for Headspace, and they've done a good job doing research. This study came out this summer, and what was interesting about it is they actually made a placebo version of the Headspace app. And you say, what is a placebo app? In this case, a placebo app was they had the same person who narrates the mindfulness give narrations, but they were not actually clinical mindfulness. They were just basically telling people to close their eyes. And in this study, when people were given the placebo app, they kind of had the same effects of mindfulness that the people that got the real Headspace app does. And so in some ways, a picture on the right of how book versus movie is, if things like mindfulness and CBT work well face-to-face, in person, just because we put them on an app or a digital format, they may not, there's going to be ways to translate them, but we may have not got that translation perfect. So I think we all know a book that we like that the movie wasn't as great, and vice versa. So I think it's worth considering, just because CBT works well face-to-face and clinic has great evidence, how are we translating it onto smartphone apps? What is the best way to make it work and not. And I think certainly people are looking at new ways to do CBT. David Moore at CBITS and Stephen Scholler now at UC Irvine have some very interesting work on IntelliCare, looking at new ways to kind of deliver therapy and CBT via apps. The other part, there's a lot of the apps out there just don't have evidence. This is a reference from a recent paper in NPJ Digital Medicine, where the authors looked at all the apps out today, and you can see from the figure very clearly, not many apps have actually been rigorously tested, and it's a useful paper to read to understand kind of the limited evidence we have about apps today. So again, just because we don't have much evidence for apps doesn't mean you don't want to use them, but it's worth making sure that you are aware, that patients are aware that, hey, this is an evolving field, this is new, we may not have a lot of evidence. It's worth discussing it. It's worth perhaps documenting it and saying that everyone's informed that this is interesting, we think it could be useful, but maybe it's not evidence-based today. And some apps do have evidence. If you actually do a quick PubMed search, there are some that have done some very impressive studies, the IntelliCare group being one of those that we just mentioned. So let's see if I go to the next slide. So we talked about engagement with, oops, we'll go back a slide. We'll go back. So let's see. Nope, this is not. Okay, there's evidence, there's engagement. So we already talked about with the example from the schizophrenia app that people were not using that app or engaging with it. And I bring up an example from asthma. This was a study that was published in Nature Biotech last year, where there was a large crowdsourced study of asthma, so not a mental health study. And the idea was you would download the app and it would learn about where you are, you would tell it your asthma symptoms, and we could learn about how the environment and asthma symptoms interact. And you can see from that figure that has the graphs going down and the numbers there, even though almost 8,000 people enrolled, there were only about 2,300 robust users that were taking a lot of the surveys, and at 6 months, they only had 175 milestone users. So engagement with apps is hard. Just because you build an app does not mean people are going to stick with it. And I think all of us know in the mental health field, from whatever perspective we're coming from, engagement is hard, behavior change is hard. And we have a paper, it's actually free online this month to read, so I highlighted it, where we did a clinical review, not a systematic analysis, but we looked at, we call it a clinical review of user engagement with mental health smartphone apps, evidence, theory, and improvements, highlighting some of the things that are kind of going well with using these apps, but some of the barriers that make these apps perhaps harder to use. So I'm biased, but I would recommend reading that, especially because you can download it free this month through the journal. So again, so talking about engagement, just like anything you would use, if you're giving people a medicine, you would have a plan for it. If people are doing homework for CBT, you would have a plan about that. It's worth thinking about that too, and understanding that apps are not going to be inherently more engaging. If anything, people perhaps may stop using them quickly from the evidence. So the questions that we propose are not the gold standard questions, but again, they're to spark a discussion, to give an idea to say, would this app be easy to use in the long term? Are the features of it customizable? Is it something that I could see myself using? Would it work for someone who has vision impairment or disabilities? Is it culturally relevant? So again, worth considering the ease of use factors in it. And then moving up to the fourth level is interoperability. The picture on the right being, on the left being, again, you don't want to silo information where one app is doing therapy, one app is doing medications, one is doing diet, one is doing scheduling, and then you fragmented mental health care. That would be, we're in an era where we want things to be integrated care. We want to have medical homes. Within the right, we want things to be connected appropriately. We already saw that sometimes smartphone apps may be sharing data with the inappropriate parties, but how can we kind of make sure that the right data is getting to the right people? And I think what is most important is if you're using an app, how is that data going to get back to a clinical session where you're going to use it to inform clinical management from a clinical point of view? How is it, if you're a person using it for self-care, how are you going to know it's working? How is it effective? How are you getting your data out of the app? These are important things to consider. And so again, we pose some questions about this on, can you share the data with an EHR, electronic health record, in the bottom right box? Can you print out your data at least? Can you export your data? Can you share it with different services like Apple Health Kit? And again, there's no right or wrong. For a reference app, this may not even matter. So, but like any decision, it's worth thinking about, when is this useful? When do you need it? What is the context? What is the patient? What is the clinical need? So there's, if you look on the American Psychiatric Association webpage, you do a quick Google search, you'll get to this page where everything I've talked about is also outlined. We're going to have some more filled out examples coming soon. But again, the point of this is not to endorse certain apps. It's to give you a framework to think about points to consider so you can have a structure for a conversation about apps and come to the right decision for the right patient in the right context. So I said, clearly we realize this is just a start. This is one effort. And I think I point you guys to that text box on the right. This was a paper that came out that said mental health messaging and prominent mental health apps. This came out a couple weeks ago saying, you know, a lot of mental health apps today really present a biased image of mental health. They say almost everyone should be using an app if you look at the app. And they kind of say to self-efficacy, you have to do self-care, because that's what apps perhaps are easiest to offer, as self-care tools. So the apps themselves may not be offering a good image of helping people understand what treatments are out there. They may be presenting a biased image of it. So I think we want to make sure that as we're learning to use mental health apps as the field evolves, we don't want to be kind of perpetuating what is not working well in the mental health system. We have a great opportunity with apps, but we want to make sure we're not kind of sending people to the wrong apps, sending people to dangerous apps, or kind of, if we don't like where apps are today, codifying that. So I think what I presented with the APA framework is a first step. Clearly, we need to have more stakeholder engagement, which is on our agenda to do. And it's something that all parties will have to be involved in. I said, there's no one single solution to apps. Again, what I presented is a model that may be useful for having a conversation in some cases, but certainly not the panacea or the ultimate fix for it. So I think with that, that may be my last slide. Our lab group has a website, digitalpsych.org, and that's the email to contact me if you have any other further questions. I know we have a Q&A afterwards, but with that, I will hand it back to our moderator. Thank you.
Thank you, Dr. Torres. Thank you very, very much for this very fascinating glimpse into something that is very, very cutting edge, the world of mobile technology. With that, let us move to our next speaker today, and he is Jay Shore. Dr. Shore has an MD and also a Master's in Public Health, and he serves as the Director of Telemedicine at the Arthur and Helen E. Johnson Depression Center, which is located at the University of Colorado Anschutz Medical Campus. Dr. Shore is the chair of the American Psychiatric Association's Committee on Telepsychiatry. So with that, Dr. Shore, the floor is yours.
Thank you for the introduction, and John, thank you for the wonderful presentation on the apps. I've decided, I debated, I like to start with the joke is I'm not a doctor, but I play one on TV, and I debated whether to use web-based video conferencing, but since they use such a youthful picture of me, I don't want to spoil your image of me by showing you what I look like now. They also gave me an MBA. I have an MPH, but I'd love to have an MBA, but I don't have one. So, okay. There's a little delay, as John pointed out in the slides. What I want to talk about today is really give you sorry, before I go into that, I won't go over the learning objectives in the interest of time, but first of all, this is just to say I do work for multiple different organizations, and the content is solely my opinion and responsibility and doesn't represent any official statement of the organizations I work for. I'm also an interest of disclosure, Chief Medical Officer of Access Care Services, and I will not be talking about that today. And I've also author of a book on telepsychiatry and health technologies by APA Publishing with Dr. Yellowlees in terms of disclosure. What I want to do is give this audience an overview of video conferencing-based telemental health. And you can assume for the rest of the time that I'm talking, if I use the term telemental health or telepsychiatry, I'm really talking about video conferencing. Certainly those are broad terms that may be used by people to represent everything from mobile technologies to emails. But today I'm focusing on video conferencing. I want to talk about its history, which brings us to important emerging models of how care is being delivered. Then I will make some comments specific to the use of video conferencing in substance use services and conclude with offering up some beginning resources for people on the call who are interested in getting into more depth on these topics. So this slide is a collage of the history of telemental health, and you can see in the top left corner is a plague doctor. Just to point out that although video conferencing has only been around for about a half century now, the concept of communicating medical problems at a distance is not new in medicine. And in the bubonic plague, they used to use bonfires to signal a town was under quarantine and for people to stay away. The next picture is of the York Retreat, which was a mental health asylum in England, and there was a nice review of letters back and forth between the doctors at the asylum and patients' family members. So this was sort of the first example of very delayed email communication between doctors and patients' families. As you see the black and white pictures on the right side of the slide, this is taken from the University of Nebraska, which had one of the first telepsychiatry telemental health video conferencing-based services in the late 1950s. So a lot of people are unaware that video conferencing has been around for quite some time. They actually, in addition to doing grand rounds and individual treatments over video conferencing in this pilot, they also provided group therapy. And the initial sort of feasibility writing around this was that this was very successful. The history of telepsychiatry from that time really occurs in three distinct phases, beginning with pilots that were often grant funded because the cost of technology was so much, and moving into the 1980s and 1990s as the technology cheapened, we began to see sustainable services arising out of institutions like prisons or the Department of Veterans Affairs, or transitioning to large hospital systems. And then the third phase that we're in the field now is really the use of these portable, mobile, almost ubiquitous video conferencing platforms, which is really opening up how video conferencing is being used. Within this context, Dr. Yellowlees and myself have made the argument that there's really conceptually based technologies that all clinicians are now really using in most of their practices that include things like emails or EMRs. Apps are beginning to be increasingly used in daily clinical practice, as Dr. Torres pointed out. It's certainly patient portals in mobile phones are. And then you have a series of emergent technologies that are still haven't been widespread. and we are still trying to wrestle with how to leverage them in mental health care. Things like virtual reality treatment, which in terms of phobia and anxiety treatment has been around for 2 decades now. Social networking, certainly we're going to see the rise of artificial intelligence, machine learning, cognitive computing in mental health, and video conferencing. But again, those are not part of a clinician's daily practice. If you trace really the history that I talked about of video conferencing, what the field of mental health did was, in the beginning, we used video conferencing and we used it independently of other technologies to really replicate what we were doing in person. You see, even nowadays, sort of the common things that happen in mental health, like initial assessments, ongoing management, therapy. That's really where video conferencing began, and certainly in the 2000s and early 2000s, that's where we were. As the decade evolved, we began to see additional technologies being used in synergistic ways in video conferencing systems. Nowadays, you see some EHRs with their own embedded video conferencing, mobile video conferencing on phones and tablets. And even more importantly, as we move to the end of the 2000s and in the last decade, what we've also seen is we're now using video conferencing to restructure how we deliver care and how mental health care is delivered. So we're not only just replicating what we're doing in person, but we're putting together new modes and ways of care with video conferencing that begin to shift the model of care delivery, how access can be increased for certain populations, and how the quality of care can be enhanced. I think another really important concept in the field to be aware of for video conferencing is this concept that was originally discussed by a man named Prinsky, and it's the concept of digital immigrants versus digital natives. And so basically this is the idea that I'm not going to say my exact age, but I'm certainly getting close to 50, and someone in my age group would really consider a digital immigrant. I really didn't begin using technologies in my life and my professional life until my late to mid 20s. This is very different than our children now, who are growing up immediately with access to mobile technologies, iPhones, iPads, apps. And it changes really not only the way we communicate as a society with each other, but how the individual patient regards and approaches technology. And one of the things that I think we're seeing more in video conferencing is that it gets more widespread and diffused across systems. Some of that is being driven by patient expectations and demands, and certainly digital natives are much more likely to expect the ability to communicate with their doctors through a range of technologies and their other mental health care providers. Regardless, though, we know through a huge bulk of literature that in all forms of care and medicine, and particularly mental health, that the primary relationship between a patient and their provider drives the outcome. And the context of how and where that care is delivered is crucial and critical. And so there is an emerging concept now in the field of telepsychiatry and technology of hybrid care and hybrid space. And this really means that as we are evolving our systems of care with technology, that the way providers and patients interact now is through multiple mediums. So they don't just interact in person, and they don't just interact, say, in a telepsychiatry, telemental health video conferencing clinic, but one often sees a patient in a blended approach, meaning one, that you may see a patient in your office, you then may follow up with them via video conferencing and mobile technologies. You may communicate with them through patient portals. You may communicate with them through the phone and mobile technologies. And so that doctor-patient relationship is really moving more and more into the virtual space. And like any tool in medicine, this virtual space has its strengths and weaknesses. Certainly there's a number of advantages of virtual space, and for particular types of patients, there may be an advantage to see them virtually or through video conferencing first. For example, I work with many traumatized females who have suffered abuse and trauma at the hands of men. And so often when I work with them, they tell me that they've been able to feel comfortable, open up, and share in the initial assessment in ways they weren't able to. And when I've queried about why they were able to do this, it's that feeling of safety and control that they get by being in the virtual space and not being in the same room with the provider initially, which really helps the rapport of the relationship. And this is borne out not only in my observations, but a number of areas of both the descriptive literature as well as the quantitative literature. I think both for the patients in terms of both access to care, privacy, decreasing stigma, feelings of safety can be some of the advantages of virtual space. For the provider, it certainly is a different experience seeing someone over video conferencing. You certainly maybe give up a little bit of that in-person presence, but you gain a little bit more objectivity. It certainly is very helpful in more dangerous settings. And from sort of a workplace recruitment and retention, we see this video conferencing opening up all sorts of environments for providers to work in. So myself and our programs, we have providers working in a number of virtual spaces, including their home environments, being able to keep continuity of care when they're on travel, of course, adhering to the rules and regulations of jurisdiction when you do that. So in addition to this virtual space, returning to the topic about how video conferencing in particular and technology is restructuring these models of care. And I'm going to give you a few examples of these. So there's, first of all, direct real-time, what we consider synchronous video consultations now, and I think most people are fairly familiar with that. There is also the ability to do indirect, or what we call store and forward telepsychiatry and asynchronous consultations in telemental health. And Dr. Peter Yellowlees and his team at UC Davis are really leaders in the field in this. And just to just give you a brief example of how this works is that a patient may come into a primary care clinic. They would have a structured video interview recorded by a healthcare professional, a standard psychiatric interview that takes a good mental health history, and that is forwarded to a mental health provider. In the case of the initial pilots, a psychiatrist, who then reviews that interview and provides a treatment planning and management back to the primary care team without ever having to see the patient. This increases both efficiency of getting the consultation done, but it also, this asynchronous allows the consultation to often occur much much quicker because you remove some of the barriers that can occur with scheduling with a remote mental health provider. Certainly, the technology has been key in psychiatrists managing population health, and I think the best example of this is integrated care. That is providing care in the primary care settings through a team-based approach. And so often, as you read in the literature, we're involved here in a number of services where both psychiatrists and other psychologists and social workers work across multiple clinics in rural areas, and that we have blended teams. We have the mental health team, which may be virtual, working with the in-person team, which includes primary care and case managers and their patients. And again, it's this video conferencing, and then these other technologies, such as obviously email and EHRs, that allow us to work as virtual team members. And again, these evolving models, and this is where I really feel the field of video conferencing going, is this virtual teaming model. And you see it occurring right now in a number of settings. You see it in emergency departments. Forensic settings have been doing this virtual teaming for a long time. Inpatient and residential care, and particularly alcohol and substance use treatment, where we're having blended teams where you have in-person team members and team members who join via video conferencing can be very effective, and again, both creating access for patients who need it, but also sort of shifting the model of care delivery and making our models more efficient. And then so it gets into developing services and the concept of tactical flexibility. I love this slide. People may recognize it from the Princess Bride, where the dread Pilot Roberts is fighting the giant, who gets defeated by this single man because he's so used to fighting big groups of people. And so as we develop these telepsychiatry services and programs, and particularly for substance use services, having tactical flexibility in the way we roll out these programs and models is critical to their success. And again, I think I've talked a little bit, or more than a little bit, about this concept of teleteaming. And again, its relevance to substance use services. As we do more and more team-based work, our traditional training doesn't often do a great job, except through exposure and training mental health professionals how to work in teams in formal ways. And then when you add the components of virtual and in-person and blended teams, it becomes even more complicated. And so there is a whole host of emerging literature, not really in healthcare so much, but in business, about best practices in virtual teams. But there's also a lot of lessons learned by groups that are doing this about some of the important techniques and tips about how to facilitate appropriate virtual team communication and the importance of team building. And I think this area, of both in terms of research and just applied knowledge and training, will become more and more critical in our healthcare systems. So I'm going to shift gears now and talk specifically about telemental health very briefly for substance use services. I'm going to go through some of the basic issues, and these apply to both substance use services and obviously non-substance use services, but I'll tailor my comments to those substance use services. First of all, I think most people are aware that licensure of professionals, MDs, counselors, LPCs, social workers, psychologists through the 10th Amendment is regulated at the state level. And so the basic rules of licensure is that people need to be licensed where the patient is physically located at the time of any virtual or video conferencing based session. Now, there are exemptions for federal systems, including the DoD, the VA, the Indian Health Service, where you can hold a licensure in the federal system, just one state licensure, and be able to work across state lines. But outside of those federal systems, that is the brief summary on licensure. Standard of care is also a moving target and a very interesting dynamic. To date, standard of care has really been focused on where the patient is located, but as we have more and more virtual services and video conferencing available, there begins to become a dual set of standard of care of not only what the standard of care is where the patient's located, but what are sort of the national standards that people doing this work and work across state lines are engaging in. I think in particular, I want to mention prescribing. There is an act called the Ryan-Haight Act. So if you're a prescriber, you need to be very aware of this act, which basically prohibits the prescription of controlled substances, including Suboxone, a MAT-assisted therapy, without seeing a patient in person first, and then once every 24 months. There are exemptions in the Ryan-Haight Act, which I won't get into the details. In addition, when prescribing controlled substances across state lines, you need to not only be aware of this act and the federal rules and regulations that govern it, but each state may have a different set of rules and regulations for a provider license in that state around controlled substance prescription, and so prescribers need to be aware of all of these and adhere to them. Moving on, administratively, a couple high-level things to consider that every telemental health service I've ever been involved in has a workflow and protocol that helps people clarify communication, particularly as I mentioned these teams that may be working across large distances with each other, that delineates roles and responsibilities, as well as how to manage contingencies such as loss of technology, loss of communication, and address mental health emergencies such as medication side effects, suicidality, homicidality, grave disability, which have all been very successfully managed over video conferencing. And there's a whole literature around emergency management and very nice case examples that give people guidance on best practices here. The other thing about administration, particular relevance is, of course, funding and the sustainment about these types of services. And we are in a very complex and dynamic funding environment, and most large successful programs may have a blend of funding that includes both direct services, contract billings, and grants. And really, as people develop services, thinking about sustainment issues in the beginning. The country is replete with amazing telepsychiatry, telemental health services that were very effective in treating patient populations and helping increase access, but because sustainment wasn't paid attention to, faded away after the initial grant or bolus of funding that got them started. Within substance use services, we're seeing a range of provision of video conferencing based care. It's being done in outpatient services. specific substance disorder services in outpatient clinics, integrated care with specific substance services teams to provide primary care consultation. There's a number of examples of inpatient or residential treatment programs that have video conferencing team members and do aftercare via video conferencing. There are important process issues to attend to with regards to this that I've alluded to previously in my comments. Again, the how to work with hybrid relationships, and particularly in substance use services when there's both medication that's occurring, but also maybe monitoring in terms of monitoring of sobriety and biological monitoring. And so having clear boundaries, rules, communication, and guidelines about how this is going to work across various teammates, technologies, and the patients to successfully accomplish this is critical. Also, being able to, one of the nice things about the video conferencing technology, it can really enhance getting families involved in treatment even at a distance, as well as enhance getting collaterals through various opportunities of video conferencing and engaging families more in treatment. But obviously, clinicians doing that need to be aware of how to manage group and group dynamics over video conferencing. And then some concluding comments on resources before we move on to Q&A. I'm just going to highlight a few. And I'm here today, as already discussed, and so is John, wearing our American Psychiatric Association hats. The American Psychiatric Association has a really nice a web-based tool, telepsychiatry information page. You can see the address on this slide. Most of the content there is open to the public. I think there may be a few sort of member-only content, but there's a lot of content available. Within that telepsychiatry site, we have a document available called the Best Practice in Video Conferencing-based Telemental Health. This was a recent guideline best practice document done in partnership in conjunction with the American Telemedicine Association that really provides a high-level overview of other guidelines. I'll talk a little bit more about that. And then we also have a specific toolkit, which I'll talk about a little bit more detail. Here is the best. Here's the guidelines that were published in April 2018, and basically, this document, as I mentioned before, was a collaboration between the APA and the ATA, and it really correlated a number of documents, guidelines, and best practices between these organizations in a summary format to provide a high-level overview of the state of the field and best practices in telemental health. It's broken down into three main sections: administrative, technical, and clinical. And so it's a wonderful place to start for those not familiar with sort of best practices and guidelines in the field, of which there is a host of. In fact, a recent review, there are over 50 sort of best practicing guidelines resources in telemental health now, and you can see we took the main ones coming out of the APA and ATA and updated and summarized them in this document. Again, it's available on that website. So that is the best practices. And then our toolkit, if you go to our website, it covers 30 plus areas in telepsychiatry. And you'll go on and you can see, you can look on the left your left side, you click on telepsychiatry, and then this is media communication skills, one of our 30 areas we cover. Each area gives a high-level bullet point of what are the key sort of takeaways in that area, and may provide some additional reference and linkage. And then each area has one of our committee members and or all who are experts in the field of telemental health, giving about a 2-minute high-level narration and overview of the field. So you can see this is media communication skills. That's Dr. Peter Yellowlees giving a highlight and giving a brief demo. And so it's especially for those new to this area, I think it's a wonderful place to start to get some overviews of the key topics. This is just a very brief suggestion of some places to start of reviewing. I did not focus on the literature and the evidence as much today, but I would say there is 3 decades now worth of evidence around using video conferencing in telemental health. I would argue it's an evidence-based practice. There's about 50 to 60 good RCTs now, all demonstrating at the end of the day equal outcomes when comparing video conferencing-based treatments with in-person treatments, although there are nuances and differences and strengths and weaknesses. So here are some recent good places to begin, but there is a large and growing literature in this area that you can delve into. So here are some beginning suggested references. And so I believe now, so that's the end of my remarks, and I'm not sure, Alan, how to do this, but I believe we're moving into Q&A, and I will turn it over to you, I believe, to guide that Q&A.
We will, yes. Thanks, Dr. Shore. Thanks so much. And yes, some questions have come in, so I'll ask the questions and of both of you, and you can provide your answers. And just a reminder to our listeners that you can submit your questions via the chat box feature on your screen. Going back to John Toros with the mobile apps, we were wondering, have you come across the website cyberguide.org? And if so, do you have an observation about that particular resource?
So CyberGuide is one of the many repository websites that kind of offers scores or assessments of apps. There's one called mindtools.o. There's one in the UK called Orca. So it's one of these repositories. Again, some people may find repositories helpful. I think, as we all know from looking at our own smartphones, it can be challenging for any repository to keep up with the changes in mental health apps, and it can be hard for any repository to give recommendations that are relevant to a patient. Again, it's one thing to say medicine, it would be like saying medicine X is the A+ medicine, or we scored it. So because we don't know what a gold standard is, we don't know who the patient using the app is, and these apps update, I think repositories have a pretty hard challenge in what they want to do.
Okay, thank you. And staying with you, John Toros, with regard to this very new world of mobile apps and mobile technology, do you foresee a potential for regulation, say by the FCC or the Federal Trade Commission, or perhaps the issuance of guidelines from either the APA or SAMHSA?
So I think the regulatory landscape is in flux. There's a new program from the FDA that's going to look at software as a medical device. It's one called the pre-certification program. So the FDA is considering moving the entire regulatory process for apps towards app developers, because they too have realized the problem of repositories is the apps update and change too much. So the FDA has proposed, will we regulate an app maker? For example, if Apple were to make an app, would Apple get FDA approval to make FDA-approved apps, and the FDA would do post-market surveillance? So that's something the FDA is considering, because they've also realized it's impossible to keep up with the landscape in the repository way is not going to work. I imagine that the FDA will reach out to groups like SAMHSA and the APA and other expert groups to offer their expertise to different patient groups, to PCORI, to learn about what are all the things we need to consider. So I think we will see changing regulation. Right now, I think we are seeing a free-for-all. And again, there's advantages because you want to encourage innovation, but you also don't want there to be dangerous and unhelpful things out there.
Great, thanks so much. Well, turning to you, Jay Shore, with regard to telemental health and video conferencing, is video conferencing considered face-to-face time with the patient and provider as defined by CMS? The caller asks, some billing practices restrict covered services to a face-to-face encounter. So is that considered face-to-face time?
It is, but the billing area is very complicated. There are different regulations around Medicaid and Medicare. And of course, Medicaid is state-based. And so each Medicaid plan may have different reimbursements. Additionally, then you have private insurance, which is more and more frequently reimbursing and beginning to allow video conferencing as equivalent. You also have a number of states who've enacted telehealth parity laws that say specifically that if a service can be rendered with the same quality of care in person as it can over video conferencing, then insurance companies and providers must reimburse it at comparable rates as the in-person service. And so the ATA actually has, and I think most of this, the American Telemedicine Association website is available and public facing to the public, and they do a pretty good job of keeping it updated about particularly Medicaid and Medicare and what's going on at an individual state level in terms of billing and reimbursement in telehealth and telemental health. And then I also think they may have some information as well for the with the private insurances. And so that's sort of what you need to do is wherever you're located, you have to figure out what the local payers are doing around that.
Great, thank you. Well, this next question I think is directed to either one of you, so perhaps we can have both of you take turns at this. Is there any evidence that the difference in technology used has different effects on patient outcomes? John Torres, maybe we can go to you first.
So I think I'll take a quick answer. I think we're the evidence that how these apps, there's a lot of evidence that are collected on these smartphone apps, but a lot of studies may be done recruiting people on Craigslist who may or may not have a mental health condition. We actually don't have a lot of evidence on the populations that we're interested in that we want to target these things to. So I think we have some interesting pilot studies, but how do these things differ by age, by technology literacy, by where people are on stages of change? We haven't done a great job customizing what are people's needs, what are the demographics, and how can we match those to the best kind of digital health resource out there. I think we're still kind of in the early days, especially for the apps, I'll pose that, where we're creating them, but we're not doing the kind of implementation assessment research that may be necessary to fully answer that very good question.
Mm-hmm. Great, thanks. And Jay Shore, so the same issue, do you think that there is any evidence of a difference in patient outcomes using video conferencing versus not using it?
So I think there's two levels to that question. One, the studies to date and the RCTs, the overwhelming weight of the evidence shows that you have equivocal outcomes in person and face-to-face. But I think there's a more subtle question about how and when and which technologies to use with patients. And I think you talk to clinicians who are doing this work, particularly hybrid work where it's video conferencing in person, phone, they may be using apps as well in the treatment. it's learning which tool to use with which patient when. And we've really done a poor job. We've researched these kind of gross equivalent outcomes looking mainly at symptom remission and control, which is right what the standard literature does. But we haven't delved really deeply into the impact of the hybrid relationship and sort of the strengths. And, my experience, again, as a clinician, I'd much rather be able to see a patient who's been traumatized for the first time over video conferencing than in person. I also can tell you I've worked with mildly intoxicated patients, which took me longer to pick up over video conferencing than it did in person. And so, all things being equal, I would maybe prefer to see that patient in person rather than video conference. There are no absolute contraindications to video conferencing for any patients, so that's important to know. But like I said, I think where we really need to go into the research is understanding the strengths and weaknesses of these different medium, and then particularly in video conferencing, we now have different ways to video conference. So myself and colleagues are doing some in-home video conferencing, and you may be seeing patients, there's a real strength to see them in their in-home environment, but the platform may be a little different than seeing them in a big clinic with a big video conferencing setup. You may have less of a visual field range of what's going on, so there's a lot of nuances. So even in video conferencing, when and how is it appropriate to see someone via a mobile phone versus an iPad versus a large video conferencing setup versus web-based video conferencing. And we just don't have enough data, research, or clinical experience to make sort of definitive comments and statements on that at this point.
Okay, thanks very much. Just a brief programming note. We may stay a little bit beyond the top of the hour because this conversation has stimulated quite a few questions, and it would be nice to get to all of these questions. So, gentlemen, if it's all right with you, we may just stay for a little bit of time beyond the top of the hour. Jay Shore, staying with you, does one need a special release of information form to speak with a client via teleconference?
This is also an interesting question. I think there's two questions. There's a form and there's a consent issue. So every patient needs to have some kind of consent process when you first start video conferencing, which includes not only, I think it's implied that the patient's known that they're being seen over video conferencing, but it talks about how you guys are going to communicate, after hours coverage, emergency. That needs to be part of the consent process. Whether a signed form is required it's dependent on the organizational system you're working in, the state, because different states have different regs, and the funder. So, for example, in the state of Colorado, to bill Medicaid, you're required to have a written release and consent. In terms of good practices in Colorado, you're required to do a consent, but it doesn't need to be written. In the University of Colorado system, one of the systems I work, we do have a written consent that's required by the organization. In some of the other organizations I work with, a written consent is not required. And so, again, I think individual providers need to find out what's right for the system and organization they're working with from a regulatory standpoint, including state regs. And then also, again, regardless of that, like any patient procedure, there is an orientation and consent. And so typically I actually have a 2 to 4 minute spiel, depending on the patient, before I even begin working with them for the first time over video conferencing that involves both sort of patient education, but a time for question and answers and a verbal consent process.
Well, staying with you, Jay Shore, now we're turning to the issue of confidentiality for substance use disorder. 42 CFR Part 2, is that more strict than HIPAA? governing confidentiality issues for the client in using telebehavioral health?
Is that more strict than HIPAA? So that's, I think a lawyer is more apt to answer that. But so there's sort of two philosophical things. HIPAA is sort of a process, not sort of a one-off. And so when you're doing video conferencing, there are some standards around video conferencing for HIPAA, which include levels of encryption that you need to follow. But you can have a HIPAA compliant video conferencing system, but be using the video conferencing based on all your other processes in a non-HIPAA compliant way. Then this additional consent around mental health and particularly HIV substance use diagnoses that are required really depends on what, are you within the organization? If you're the remote provider of video conferencing and credentialed by them, who are you communicating with, when and how? And so that's also kind of on a service by service, case by case jurisdiction basis about what needs to happen. So it's hard to answer what's more or less strict, but both of those need to be considered and addressed when doing this, and particularly the rules and regulations around if you're doing substance use services about when and how you're supposed to disclose and get consent from patients.
Okay, and staying with HIPAA, but turning to you, John Torres, does HIPAA or any other privacy law apply to the suite of mobile apps?
Yeah. So I guess the first part is a lot of mobile apps, if you do read that fine print, will actually say we are not a healthcare service or device. We're a wellness. We fall outside of the healthcare realm. If you actually want to see a mental health provider, go find a clinician, we're off the hook. So in that case, HIPAA does not apply. As Jay says, a lot of it's how you use it, who is kind of prescribing it, ordering it. So some of these apps are beginning to pursue FDA approval, but the vast majority of apps, if you go to the iTunes or Android store right now and download it, actually are going to have this little clause that says, we are not even in the healthcare space. We're an educational wellness tool. Therefore, healthcare laws like HIPAA don't even apply to us. Instead, look at the privacy policy, again, which that's where we get into some issues of they're acting like healthcare services, but they're denying kind of any responsibility. And it's interesting, we haven't seen any class action lawsuits on this because the standard HIPAA probably applies. If a reasonable consumer thinks you're a healthcare service and you're marketing yourself like that, that's probably the legal standard. So it's interesting that we haven't seen anyone kind of bring legal action against some of these mental health apps that perhaps are giving false marketing. But so it's a complex question. I think we'll see in the next year probably case law beginning to dictate where is the fine line between a mental health app. Is it a wellness or device, or is it a mental health thing?
I was going to ask if there's been any lawsuits due to breach in confidentiality or anything like that. So time will tell, it seems. Staying with telepsychiatry, it looks like this participant is writing from Ohio. Does the virtual presence of a psychiatrist to a provider's clients constitute having met the standard for clinicians who must provide any Medicare-eligible service in incident to, quote unquote, a physician being on site during the service as required in Ohio for counselors who bill Medicare?
So
I don't know if that makes sense to you.
Yeah, I won't comment on any because I just don't know the state rules and regs. So I would have to take a pass on that. That's a direct, really good direct question to either look at the website in Ohio or even seek clarification about what's required. And again, that you've got requirements for billers to be able to bill, and you also, and again, it's variable by state to state. I practice in a couple states, and there are actually sort of different standards of care and some rules and regs around documentations that vary in the states I practice. And so I tailor my practice to be compliant with those. And so I would just say, probably the best thing to do is ask the local Ohio Health and Human Services about their policies there.
Okay. And going back to you, John Toros, with the mobile apps, what are some specific challenges or perhaps research trends in using persuasive technology to improve the client's engagement with the mobile health application?
I think that's an interesting question, kind of saying, can we perhaps can we increase the uptake, perhaps engagement of these apps through different features? I think we've seen a first wave where people tried to just gamify these apps, where people have tried to let people personalize the apps. We haven't really seen the kind of quality studies looking at what you said, different kind of persuasion, different messaging. I think we've seen some interesting small studies, but we haven't kind of seen the direct head-to-head research that all of us listening would want to say, hey, this works best in this case. I think it's going to be, I imagine the potential of these apps is you can customize them, and we know certain people respond better to certain types of communication or motivation. So it may be a case where eventually we figure out, based on, say, me, John, I respond best to this type of motivational interviewing, and this is going to be a more effective app for me. But I don't think we're seeing kind of the substantial evidence for that. And when I say substantial, I mean reproducible, where one group does it and a different group does it and says, hey, this finding holds.
Mm-hmm. Turning to you, Jay Shore, a vendor has offered telemental health services to support primary care clinicians who prescribe MAT, an 8 to 12 week program with telemental health services. Do you have any experience with such programs, or are you aware of an evidence base to support this concept?
So I am aware of some growing programs and discussions in this area. And so it depends how you define MAT, right? I mean, I think often people immediately think Suboxone, but there's also naltrexone, acamprosate, antabuse, right? There's all sorts of medication-assisted therapy that don't fall under sort of that controlled substances. So there are some growing pilots and programs that offer that support into primary care. And I think conceptually, there's a lot of programs now doing integrated care via video conferencing and telepsych. And so doing MAT or offering MAT as one of the content of the integrated care support, I think is a very legitimate approach. I obviously couldn't comment on devils in the details, what the vendor's model is and how they're doing it and how it goes back and forth with the specific approach. But the general sort of concept is being discussed. It's certainly been being done in some small pilot areas that I'm aware of, and it's following, these larger, where there is this evidence for doing that integrated care telepsych that's robust and out there.
You may have touched upon this in your remarks, but what are the laws regarding providing telehealth counseling sessions for patients who are on vacation in a different state?
The conservative answer to that, because I get this a lot, if you look at the state regulatory bars, it's sort of interesting because phone calls, if somebody needs a little bit of help and they're your patient and you call them up, and they're existing patient, they're on vacation and you help them, I really haven't heard state medical boards being concerned about that. And some state medical boards may even have rules and guidelines that, specifically say that is okay. Once you do video conferencing, the state boards feel very, very differently about it. And it's very clear that the FSMB, and I've been involved in these discussions, and they're clearly from them, that video conferencing constitutes sort of a different animal. And so technically, if you are video conferencing with a patient and you're not under federal jurisdiction under one of these exemptions, you need to be licensed where the patient is. And so, you can create a situation where you might take a phone call and really not run, against sort of the local state medical board. But once you video conferencing, from a conservative interpretation, you're out there, and that's the advice I give to people. If you're going to see a patient over video conferencing, you need to be licensed in the jurisdiction in this country where they are. Although this is a dilemma that frequently happens, either vacation, and then a lot of psychiatrists, if patients are moving, they want to provide some temporary coverage, or someone's going off to college. But the bottom line is, you need to follow the rules around state licensure, which is to be licensed where you're providing care.
Great, thanks. One participant offers this comment. This is with regard to the regulatory environment. The FDA is already regulating software as a medical device. The first psychiatric substance use disorder app cleared as a Class 2 device is the product Reset, developed by Pear Therapeutics. And as a note, we did actually have a representative from Pear Therapeutics present about Reset and the Reset specific for opioid use disorder earlier in our webinar series earlier this summer. I think we'll probably do one or two more questions because we are approaching 10 past the hour. On a practical basis, how does the patient obtain a paper prescription for controlled substances if the prescriber is working from a remote location?
Well, so first of all, right, if that prescriber is working, Ryan Haight would dictate that prescriber has a relationship and has done an in-person exam. So let's assume that they're compliant with that. Then, secondarily, you've got to look at the state's rules and regulations on controlled substances. Some have triplicates and some don't. And so I've seen everything from FedExing prescriptions, particularly with paper prescriptions, or having to mail it in secure, sort of a secure registered mail situations, through going through a larger system, to working with colleagues on site with the patient. And so as you develop these, if you're working in a service and not just seeing individual patients, then that's something you work through in the beginning before you start seeing patients. How are we going to address this? How are we going to comply with Ryan Haight? And then as we comply with Ryan Haight, how we issue these prescriptions. And there's a number of different solutions I've seen with different systems.
Okay, let's go to our final question then. Where does one find the regulations for a specific state regarding telepsychiatry?
There's a couple. If you're looking broadly, ATA and then the Center for, I believe it's called, I should Google it right now, but Center for Telemedicine and Law, they actually have some nice state-by-state summaries, like all 50 states. And so those are some good resources to start with. If you're practicing in a state, it's really in the Medical Practice Acts, and you usually go to a state website and sort of, and some states have really good, and you put in the search and it's right there and it's very clear, and rules and regs around telemedicine. Other states, getting the most current rules and regs can be a little bit challenging on their websites to navigate that. And sometimes they're not sort of consolidated in a single place, and there may be multiple statutes too. So you do have to do a little bit of legwork and groundwork with the the jurisdiction. But if you're at that level, clearly you've probably already obtained a license in that state. And so as you go through the licensing process, there's often education and information that you can find around telemedicine.
Great, thank you so much. As someone who continues to print out his emails, I do consider myself a digital immigrant. So thank you so much for your observations. John Torres and Jay Shore, thank you so much for presenting to us today. Just a reminder to our participants that this webinar will be archived on the YouTube page at www.samhsa.gov. And there's a screenshot of it. There is about a 2-week lag time before this webinar will be archived. So if you are looking for it, give us about 2 weeks to place it there. So with that, on behalf of SAMHSA and the entire BHITS team, let's thank Dr. John Torres and Dr. Jay Shore, both from the APA, for speaking with us today. Their contact information is on the screen. And so with that, thank you for attending today's SAMHSA webinar, and we wish you all a good afternoon. Take care.